systemic vascular resistance. It is now clear that unless contraindicated, it should be given to all patients with impaired ventricular systolic function. Both cardiac output and cardiac index increase as ACE inhibitors reduce aftergrowth. Some ACE inhibitors, captopril, enalapril, lisinopril, benazepril, ramipril, and perindopril. ACE inhibitors induce a Haque, bothersome dry cough, and it is not dose related. Occurs more frequently in women and usually develop between 1 week and 6 months after initiation of therapy. There is some information here. Sometimes it is so severe that requires cessation of therapy, and it sometimes induces skin rash, rapid swelling of the nose, throat, larynx, lip, tongue, called the angioedema. Some angiotensin 2 receptor blockers, ARB, elbisartan, ibisartan, losartan, olmesartan, and valsartan, used in ACTN, heart failure, diabetic nephropathy, and stroke prophylaxis, etc. Unlike ACE inhibitors, ARB do not cause cough and angioedema. Asthma with arrhythmias. This is more one comorbidity condition. Calcium channel blockers, that is diltiazem, verapamil, are used in supraventricular arrhythmias. Example, atrial fibrillation. Dioxin is the drug of choice to control ventricular rate. Amiodarone can be used. Try to avoid aminophylline or theophylline to treat bronchial asthma in this comorbid condition. Asthma with arrhythmias, continue here. If we use beta agonist, especially long-acting benbuterol, not salmeterol, it is less risk in heart failure, and patient may have harmful effect. Topical delivery for recommended dose has few side effects. At higher dose, both long-acting and short-acting beta agonists may lead to increased heart rate and cardiac arrhythmias. Some words on theophylline. Theophylline is methylxanthine, is among the least expensive drug used in bronchial asthma. Rapid intravenous administration of therapeutic dose of aminophylline sometimes results in sudden death, probably due to the cardiac arrhythmias. Additional symptoms of toxicity includes tachycardia, restlessness, agitation, and emesis. Steroids. Drugs, common drugs for management of bronchial asthma. Inhaled corticosteroid produces some local effects on oropharynx. Dose between 800 microgram to 1600 microgram. Hypothalamo-pituitary adrenal excess suppression is difficult to document. Fluid and electrolyte handling can causes hypertension and ISD. Nicotine receptor antagonist. Montelukast, Zappilukast, and Pralucast is some example. Owing to their anti-inflammatory properties, have been the primary therapies in bronchial asthma. The use of nicotine modifiers in treatment of inflammatory component of cardiovascular disease encompassing atherosclerosis, AMI, stroke, and aortic aneurysm. This is new information. Conclusion. The asthma patient who develop angina or hypertension is at risk of having beta-blocking drugs prescribed and thus being forced sometimes acutely. Alternatives for hypertension are diuretics, methyldopa, reserpine, captopril, prazosin, or nifedipine. For angina, vasodilators such as nitrates, verapamil, nifedipine are acceptable. From the pulmonologist point of view, management of bronchial asthma may have many harmful effects on cardiac diseases. Angina and ventricular extrasystoles are reported on beta-2 agonist using nebulizer or oral form, but not in metered-dose inhaler. On the other hand, from the cardiologist point of view, drug used in asthma may be undesirable. Beta-2 agonist in high dose may worsen angina, and steroid commonly promote fluid retention and hypertension. Judgment is therefore necessary of both pulmonologist and cardiologist in making decision on an optimal drugs and doses. Thank you all for listening.
Dear audience, Assalamu alaikum. First of all, I draw your attention. হাঁপানি রোগে বয়স্কদের চেয়ে শিশুরা বেশি আক্রান্ত হয়। পরিকল্পিত চিকিৎসায় শিশুরা রোগ মুক্ত হয়। অ্যাজমা অ্যাসোসিয়েশনের একটি ব্যানার। But I'm sure here is a representation from pediatric pulmonologist is very poor. So I have to present my childhood asthma management from the adult respiratory medicine specialist and surgeon. Because সবার জন্য প্রশান্তি ভরা শ্বাস চাই। Around 300 million people are asthmatic all over the world. Another 100 million will be added by year 2025 in Bangladesh. 7 million are asthma patients. Majority of the patients are in the age group 1 to 15 years, that is pediatric age groups. So 4.7% of pediatric patients are asthmatic. 90% of the asthma patients are not taking modern treatment. It is very unfortunate. World Health Organization shows most asthma-related deaths occur in low and lower middle-income countries. Asthma is underdiagnosed and undertreated. The strongest risk factors are inhaled substances that may provoke allergic reactions or irritate the airways. Medication can control asthma. Avoiding asthma triggers can also reduce the severity of asthma. Appropriate management of asthma can enable people to enjoy a good quality of life. And Asthma Society of Canada says worldwide the economic costs associated with asthma are estimated to exceed those of TB and HIV/AIDS combined. Here is the definition, you all know. Now, from Expert Panel 3 of National Asthma Education and Prevention Program, USA, classify asthma from clinical point of view. The intermittent on persistent, acute exacerbations and special variants. Here is the intermittent asthma, you all know. Persistent asthma is again divided in mild, moderate and severe one from symptoms and from PEFR and FEV1. Acute exacerbations is also divided in mild, moderate and severe for management. And these are special variants: seasonal, exercise-induced, drug-induced, cough variant, and occupational. And diagnosis and investigations. Diagnosis we can do it from clinical criteria and from some laboratory criteria. These are the clinical criteria: paroxysmal respiratory distress, recurrent cough with chest tightness, recurrent attacks due to multiple stimuli, and from laboratory criteria, eosinophilic inflammation is from sputum eosinophilia, pulmonary function test, obstructive defects, at least partially reversible by the drug. For diagnosis and for differentials, we can do some investigations. And now the management, we can manage it in home and emergency management at home and in hospital. This is the home management. These are two. With guided self-management plan, here we follow the big flow chart, that is, you know, the green, yellow and red zone, and how to modify the drug dose up to a certain limit. And another, without self-management plan, here we follow the step care management deployed along with some patient education with scoring system. There is a step care management for more than 5 years older children. Step 1 to step 5. Here we start with short-acting beta agonist, 2 puffs at a time, as and when required, and before 2 puffs before exercise, sports, and exposure. These are the triggers. And step 2, we can use low-dose inhaled corticosteroids or other drugs like leukotrienes, full-dose chromones, or theophylline. And step 3, high-dose corticosteroids or other drugs. If used low dose, we may use with LAVA, theophylline or full-dose chromones. And supplementarily, we can use leukotriene antagonists. In step 4,